Good morning, everyone. It is my pleasure to introduce Dr. Ravindran. So Dr. Aishwarya Ravindran, she's an assistant professor of pathology, Division of Laboratory Medicine, Hematopathology, Department of Pathology, University of Alabama, Birmingham. She's a consultant hematopathologist and associate scientist in cancer control and population science at the O'Neill Comprehensive Cancer Center at UAB since July of 2022. She received her medical degree from Stanley Medical College in India in 2013. Subsequently, she pursued her research fellowship in hematology, followed by a residency in anatomic clinical pathology and fellowship in hematopathology at Mayo Clinic in Rochester, Minnesota. From 2015
Dr. Mogrovejo, if you'd like to start.
Oh
please.
My God, they were not listening.
I'm upstairs.
Can you hear me?
We can hear you online.
Yeah, we heard you fine.
Okay. Okay, so I was good. Okay, sorry. So I will continue. During her research years, she developed a special interest in studying rare diseases, specifically histiocytic dendritic cells neoplasm. She currently co-leads the histiocytosis program at UAB with clinical hematology. Besides a busy clinical practice, her academic research...
Okay, we can't hear you. Can you put the small microphone on?
No.
Amy,
we can all hear her. It might be your computer.
You won't hear me.
I'll text her.
Yes.
I can hear you.
Okay. So she has published numerous peer-reviewed scientific articles, and I was also a recipient of the Mayo Clinic Dr. Howard Alibach Fellowship Award and the American Society of Clinical Pathology for under 40 honoree from the outstanding contributions to the field of pathology. She's an active member of the Multi-Institutional Histiocare Network, and she aims to improve awareness about these rare diseases. She will soon be joining Mayo Clinic Hematopathology on staff in May 2026. So welcome, Dr. Ravindran.
Thank you, everyone. Thank you, Dr. Ramas, for the kind introduction. And it's been an honor to be able to present this grand rounds today. Can anybody confirm online that you're able to hear me and you can see the screen?
Yes.
Okay, perfect. So histiocytosis, this is my central area of interest for a very long time, almost over a decade. It all began in 2016 when I saw my first patient with Rosai-Dorfman disease when I was a research fellow in hematology at the Mayo Clinic. I think since then, over the past 10 years, it's been a very humbling and enriching educational experience for me. And today I take this opportunity to share with you some of the key insights and lessons I've learned about diagnosing histiocytosis in day-to-day pathology practice. So I have no disclosures relevant to this talk. So the primary learning objectives of today's presentation is going to be to understand the nomenclature of histiocytic and dendritic cell neoplasms, and to characterize the phenotypic spectrum to help histopathologists in diagnosing these entities. And finally, to recognize the practical challenges at the scope of clinical practice, primarily focusing on overdiagnosis of these entities. You know, these entities are very rare. As much as underdiagnosis is common, there are also the other spectrum of overdiagnosing these histiocytic disorders. So the outline for this presentation, I will begin with an overview with focus on nomenclature and classifications, followed by a case-based approach with focus on diagnostic pitfalls, phenotypic correlates, and some practical challenges at the scope, and followed by an approach to a histopathologic workup and diagnosis, and finally concluding the presentation by briefly summarizing the approaches in the multidisciplinary histiocytosis working group in dealing with these rare diseases. So coming to the introduction point, what are histiocytes? Histiocytes are tissue-resident macrophages or dendritic cells. They derive from the mononuclear phagocyte system, which is comprised of your immune cells, which is monocytes, macrophages, and dendritic cells. So let's go to embryogenesis. The ontogeny of mononuclear phagocyte system begins in the time of conception. The yolk sac is the primary site of hematopoiesis up to the day 32 of gestation, and followed by which the fetal liver takes over hematopoiesis. But one of the very fascinating physiologies of this mononuclear phagocyte system is that the resident macrophages such as your Kupffer cells in the liver, your osteoclast in the bone regions, microglia in the CNS, Langerhans cells in the skin, are derived from your embryonic precursors, which is from the yolk sac and fetal liver, and they are in a state of constant self-renewal, independent of the bone marrow throughout the adult life under homeostatic conditions. So apart from the resident macrophages, at the time of birth, the bone marrow becomes the primary site of hematopoiesis, and it gives rise to the monocyte dendritic cell progenitors, the MDP. So the MDP gives rise to the common monocytic precursors, which gives rise to the monocytes. Monocytes can differentiate into macrophages as well as dendritic cells, and monocytes are your primary immune cells of the innate immune system, responsible for dealing with pathogens and inflammatory disorders. Now, coming to the common dendritic cell precursors, they give rise to classical dendritic cells as well as plasmacytoid dendritic cells. Your classical dendritic cells are two types, CDC1 and CDC2. They are your primary antigen-presenting cells and play a major role in adaptive immunity. Whereas the plasmacytoid dendritic cells, they are less potent in their antigen-presenting capabilities, but more potent in their antiviral immune defenses. Now, there's a third subset. I recently learned about this 3 years ago at the Histiocytic Society meeting, which is a dendritic cell subset 3, DC3. It kind of has a unique mechanism and emulates the functional capabilities of both monocytes as well as classical dendritic cells. Now, why this is important to know about this ontogeny is because these are your immune cells that give rise or become neoplastic entities. And when they do become histiocyte macrophage, Langerhans cell, or classic dendritic cell neoplasms, the neoplasms have the same immunophenotype as their normal immune cell counterparts, which we can exploit in diagnostic practice for diagnosing these rare disease entities and characterization of the phenotypic spectrum. Talking about plasmacytoid dendritic cells, they can also become plasmacytoid dendritic cell neoplasms. One of the most common in hematopathology practice is plastic plasmacytoid dendritic cell neoplasms. It is rare on a big grand spectrum of the things, but the BPDCN is a subtype of PDC neoplasms. For the focus of histiocytosis spectrum of disorders, PDC neoplasms will not be included in the talk, and only these ones that are highlighted in red will be the focus of today's presentation. In terms of the biologic pathways involved in this histiocytic neoplasms, over the past decade, it's been shown that the MAP kinase pathway underlies the biologic evolution of several of these histiocytic disorders, nearly present in 50 to 70% of these cases with histiocytosis. The most common being BRAF V600D mutation, which is common in more than half of the patients in Langerhans cell histiocytosis and Erdheim-Chester disease. And the other mutations involve KRAS, NRAS, MAP2K1, which can be present in Rosa-Dorfman disease. But the most common pathways are the MAPK followed by the PI3-AKT pathway. Now, why this is important to understand is that now we have FDA-approved therapies, especially for adult histiocytic neoplasms, where we can target these gene fusions or genetic mutations in order to help the patients to achieve prolonged remission rates, or at least keeping the disease under control. So talking about the classifications of histiocytic dendritic cell neoplasms, to complicate even more, we have two classification systems currently. And the main things I want to point out is that the WHO classifies the plasmacytoid dendritic cell neoplasms under the spectrum of histiocytosis, primarily because of the shared ontogeny that I just described. But the international consensus classification had decided to keep PDC neoplasms and as a separate, distinct myeloid neoplasm entity, and not under the spectrum of histiocytosis, primarily because the biology, the clinical scores, genetic mutations are entirely different from other histiocytic neoplasm, although there is a shared ontogeny. The second difference in the current classification system is that Rosa-Dorfman disease and ALK-positive histiocytosis have been classified as distinct histiocytic neoplasms, primarily because the Rosa-Dorfman disease, especially historically, was considered as benign, self-resolving histiocytic disorder. It still could be in a subset of patients, but in many patients, now we've found MAP kinase pathway mutations in at least 30 to 50% of RDD cases, which has really forced the classification system to consider this as a distinct histiocytic neoplasm. Now, the third distinct difference in the classification system is follicular dendritic cell tumors. As you can see, the dendritic cell has this overlapping semantics with the other histiocytic classical dendritic cell neoplasms. But I want to emphasize that the follicular dendritic cell tumors have a completely different ontogenic derivation, and they did not derive from the bone marrow, but rather from the mesenchymal progenitor cells. And for this very reason, they also have an underlying different biological pathway not associated with MAPK pathway mutations. And hence, these entities were excluded from the WHO classification from being classified under the spectrum of histiocytosis. But ICC retains this under the histiocytic classification. I must point out this classification is up for change for residents and fellows. There's going to be a merger happening soon. So I think the initial conceptualization will take place in 2026. So by end of 2026 or 2027, we'll have probably a merged classification of all these entities, in which case we will see this FDC tumors disappear from the spectrum of histiocytosis. So the most comprehensive classification system, this is the third group of classifiers, include the Histiocytic Society from 2016. This is the most comprehensive classification of all histiocytic disorders. I say disorders and not neoplasm because not everything in this bucket is referred to neoplastic entities. They can also be benign reactive histiocytic proliferations encompassed in these 5 buckets. But having said that, the L group, R group, and M group are true histiocytic neoplasms, with the L standing for Langerhans cell histiocytosis or Iron-chested disease, mixed histiocytosis. We'll talk about this in the upcoming slides. The R group as in Rosai-Dorfman disease, and the M group comprises of malignant histiocytosis. The malignant histiocytosis is up for a new terminology, which is upcoming as the malignant histiocytic neoplasms. We call these malignant histiocytic neoplasms because of the histologically aggressive appearing morphology as well as the clinically aggressive behavior, compared to the other histiocytic neoplasms, which have a more chronic, indolent, slowly, gradually progressive course. So that's what the term malignant histiocytosis applies, and this comprises a spectrum of different subtypes. The most common subtypes you might be aware is a histiocytic sarcoma, and the other one would be Langerhans cell sarcoma, and the other 2 types was interdigitating dendritic cell sarcoma and indeterminate cell sarcoma. The word sarcoma is a misnomer, so all of these entities comes under the group of blood cancers. So talking about the C group of histiocytosis, C as in cutaneous lesions, is refers to any cutaneous histiocytic disorders. And now this C group is a very notorious group. It can range from benign, self-limiting, to all the way to malignant. And in between, there's disorders of indeterminate malignant potential. It's actually some more work needs to be done in the C group of cutaneous histiocytosis. The H group, on the other hand, refers to hemophagocytic lymphohistiocytosis, abbreviated as all of you might know, is HLH. HLH could be primary or secondary. Now, primary is most common in pediatric age groups, secondary to inherited gene mutations. Secondary HLH is more common in adult populations, where we can see it secondary to viral infections, lymphomas, and as well as other malignancies. HLH is not a pathologic diagnosis, is rather a combination of clinical and laboratory criteria with only one morphologic finding of hemophagocytosis that comes under the review of pathologists. So for the purpose of this talk, our focus will be only under the other 4 groups and not the H group of histiocytosis. So integrating all classifications, I want to clarify my intention was not to come up with my own classification system, but to integrate the classifications in an appropriate manner for the diagnostic pathologist such that we can employ phenotypic variations and detail the different subtypes under the phenotypic variations. For example, the monocyte macrophage neoplasm comprises of the 4 different entities of histiocytosis with the phenotype of positive histiocytic markers, which is CD68, CD163, variable expression of S100OCT2 with or without factor 13A. On the other end, you have this classical dendritic and Langerhans cells. I emphasize the term classical because dendritics can be plasmacytoid dendritic cells, follicular dendritic cells. So when I'm referring to dendritic cell neoplasm in the context of histiocytosis, they're almost always classical dendritic cell neoplasms, for which we can use immunostains such as CD1A and Langerhans to distinguish the subtypes from these monocyte macrophage neoplasms. The malignant histiocytic neoplasms that encompasses histiocytic sarcoma, Langerhans cell sarcoma, and other subtypes have an overlapping phenotypic characteristics of both the monocyte macrophage as well as the classical dendritic and Langerhans cell neoplasms. And in majority of them, have this MAPK pathway alterations, which can be employed for therapeutic purposes as well as prognostic purposes in these entities. So now going into case-based approach to diagnosing these different phenotypes of histiocytosis. Case number 1, this is a 60-year-old male who presented with left carotid artery stenosis, almost having a 60 to 70% of stenosis in the carotid artery, underwent carotid endarterectomy. And interestingly, there was no cholesterol clefts. The most common cause of stenosis we would think is an atherosclerotic plaque. There was like a separate plaque, like a mass that was also kind of extracted, which showed similar morphology, but this was kind of a very characteristic morphology with this wall of this carotid artery involved by the sheets of histiocytes that showed this diffuse expression of CD163 and S100. This was a case of Rosay-Dorfman disease involving the wall of the carotid artery. By far, this has been the most aggressive presentation of Rosay-Dorfman disease I've seen. I must emphasize that I come from the South, the University of Alabama at Birmingham. We see a lot of patients of the Afro-American descent. RDD has a very different clinical phenotype in Afro-American patients as opposed to Caucasian patients. So there are epidemiologic, as well as ethnic differences in presentations of this disease phenotypes. So diagnosing Rosay-Dorfman disease, as many of you might already know, that this has been historically described in lymph nodes and nodal presentations, characterized by this round and large oval nuclei with small conspicuous nucleoli and abundant pale eosinophilic to foamy cytoplasm. With frequent engulfment of inflammatory cells, the green arrows points to the small mature lymphocytes, a phenomenon called emperipoiesis. I must emphasize the fact that emperipoiesis is not pathognomic for Rosay-Dorfman disease. It's the most frequent morphologic features, but this feature can also be present in other histiocytic neoplasms as well as benign histiocytic proliferations. So this must not be classified as a defining entity for Rosay-Dorfman disease. So hence the need for a comprehensive panel of immunohistochemistry workup, including histiocytic markers such as CD163, S100 being diffusely positive, and also highlighting the features of emperipoiesis in these histiocytes. OCT2 is a B-cell transcription factor. 4 years ago, we recently described this as being highly expressed in Rosay-Dorfman disease histiocytes. In greater than 95% cases of Rosay-Dorfman disease show OCT2 expression. But when you interpret OCT2, you need to exercise caution because it can also stain background small reactive B cells as well as plasma cells. Now, cyclin D1 is a very useful marker in histiocytic neoplasm diagnostics, compared to excluding reactive histiocytic proliferations. In neoplastic histiocytes, typically you will have uniform strong expression of cyclin D1, and the presumed hypothesis is that the upregulation of cyclin D1 is secondary to underlying MAP kinase pathway activation. Cyclin D1 can be upregulated in several tumors, especially in solid tumors, including melanomas. But there could be several different pathways for cyclin D1 upregulation, but the most common pathway in the histiocytosis realm is going to be activation of MAP kinase pathway, whether or not you identify pathogenic mutations by next-generation sequencing. So talking about emperipoiesis is a phenomenon of cell passing through a cell. So you can always find it in normal cells in the bone marrow, such as megakaryocytes. You always find cells within the megakaryocyte in the bone marrow when you examine. So emperipoiesis does not cause destruction of blood cells, but when you contrast it with hemophagocytosis, this means the macrophage is engulfing the inflammatory cells or the hematopoietic processes and completely destroying it. And your clue for that is actually CBC, which causes cytopenias because of the hemophagocytosis, whereas emperipoiesis is really harmless. CD163 is known to be a very specific histiocytic marker compared to CD68, as CD68 can be expressed in a lot of other conditions as well. But CD163 can be negative in histiocytosis, especially up to 10% of Rosay-Dorfman can be negative for CD163. And also there are some dendritic cell neoplasms that can be negative for CD163. Hence the need for actually employing other immunohistochemistry such as S100 OCT2 for a reliable diagnosis of histiocytosis. Talking about Rosai-Dorfman disease as a nodal disease historically, a recent contemporary series, including our group, has shown that there's been a predominance of extranodal presentations in RDD compared to nodal presentations. I see about 3 to 5 cases of Rosai-Dorfman disease a month in UAB as new diagnosis, and majority of the times, 9 out of 10 times, it's going to be an extranodal presentation. And that's the most interesting part of the Rosai-Dorfman disease. I think extranodal is way more common than nodal, especially in adults. So some of the key things I wanted to emphasize in this graphic is that in the nervous system, you can have RDD mimic meningiomas, especially the lymphoplasmacytic rich variant of meningioma. It can also mimic malt lymphoma. So when the morphology doesn't really correlate with radiology, think of Rosai-Dorfman disease to evaluate for dural-based lesions. And in the retroperitoneum, just like Oran-Chester disease, it can present as perinephric thickening. And perinephric thickening, when it presents in this kind of a location, you also have to factor in other low-grade lymphomas. The reactive histiocytic proliferations will include IgG4-related disease. The bone lesions, interestingly, Rosai-Dorfman disease can include up to 10 to 20% of cases can present with lytic bone lesions, where your differential in adult setting will be plasma cell neoplasms as well as other lymphomas. In the orbit, your differential primarily, it's up to 5 to 10% cases can present at orbital masses, but other histiocytic neoplasm, especially Oran-Chester disease and RDD, can have similar radiologic presentations. And oftentimes it's an intraconal disease when it presents as histiocytic neoplasms on morphology. And the most common extranodal presentation is usually skin lesions, and skin lesions can range from nodules to papules to plaques, as well as to itchy lesions to non-pleuritic lesions. So there is no way to think about a histiocytic neoplasm other than morphologic examination and a comprehensive immunophenotyping, especially when it's unexplained skin lesions in the dermatology clinic. There are several associated conditions for Rosai-Dorfman disease. The most common is autoimmunity, the primary autoimmune disease being lupus erythematosus. It can also be associated with lymphomas, predominantly malt and marginal zone, nodal marginal zone lymphomas. There is a majority of these Rosai-Dorfman disease is somatic, secondly acquired in adult life, and could be somatic mutations in the MAP kinase pathway. But there is a subset of familial Rosai-Dorfman disease. It's called this SLC29A3 spectrum of disorders. You may come across terminologies like Faisalabad histiocytosis, H syndrome. They really have this genetic predisposition to develop Rosai-Dorfman disease. And when to suspect this, if the patient has a family history of Rosai-Dorfman disease, secondly, when they're presenting in infancy or toddler stage, to really look into these mutations for analysis. So talking about the associated conditions, we did a multi-institutional study looking into about 157 patients of Rosai-Dorfman disease, where we found that at least like 20 to 30% of these cases of Rosai-Dorfman disease had a positive autoantibody or an autoimmune disease. This is definitely 2 to 3 times higher of autoimmunity in Rosai-Dorfman disease compared to the general population, which begs the question if this is an exaggerated immune response that acquires clonality in a subset of cases, but in the remaining subset of cases just behaves like an exaggerated immune response, which could be self-resolving or sometimes necessitating treatment. Talking about BRAF V600E expression, it's extremely rare in an isolated case of RDD. Less than 1% of the cases usually have BRAF V600E. When you have BRAF V600E in Rosai-Dorfman disease, almost always you have to think about mixed histiocytosis. And what is mixed histiocytosis? This is defined as synchronous or metachronous involvement by more than two or more histiocytic neoplasms, either in the same sites or different sites. And I've seen collision tumors of Rosai-Dorfman disease with LCH in the same tissue biopsies. You can see this in pediatric age group more commonly. And sometimes what happens, Rosai-Dorfman disease can be in a different sites, typically testicular involvement by Rosai-Dorfman disease, but the patient has a systemic Oran-Chester disease with involvement of other multi-system involvement. The key thing for this, what is the significance of this, is that more than 95% of the cases have a driver mutation. And most oftentimes, the most common mutations are BRAF V600E, MAP2K1, PIK3CA, as well as KRAS and NRAS mutations. And it's important to keep this in mind because prognostically they can be still variable. We're still learning about the mixed histiocytosis entity. What is your long-term impact? But this is something that always needs to be entertained when you're seeing differing morphologies in the same site or two different sites in the same patient. So case number 2, this is a 30-year-old male who presented with progressive bilateral diplopia for 2 years. MRI revealed a T2 hypointense lesion, which was highly suggestive of meningiomas. And when you can see this MRI, the imaging finding here, you can see this kind of a lesion, which was about 2.5 centimeter and so forth, which is highly suggestive of meningiomas, and patient went with progressive vision symptom without a biopsy because it was during the COVID time. So eventually a biopsy was performed in 2021, and the patient biopsy showed this diffuse lymphoplasmacytic and histiocytic infiltrate. It was negative for meningioma, negative for lymphoma, negative for all other epithelial and nerve sheath tumors. So at this point in time, I told you, just like I mentioned before, Rosai-Dorfman disease can mimic a meningioma. So this is when I got involved. When we did a workup for histiocytic markers, it was positive for CD163, S100, and cyclin D1. Cyclin D1, you can see this inset that shows this emperipoiesis in this histiocytes. But however, the OCT2 marker was negative. OCT2's usually it's negative in the setting of mixed histiocytosis when Rosai-Dorfman disease presents with ECD. A de novo Rosai-Dorfman is typically never OCT2 negative. So this kind of gave me a pause on this case. Could this be something else? But certainly had this RDD type of presentation on radiology, as well as the immunophenotypic features were suggestive of RDD, except for the OCT2 immunohistochemistry. But further delving into other immunohistochemistry, it was diffusely positive for ALK, that is cytoplasmic expression of ALK in this histiocytes. And by NGS, it showed a KIF5B, ALK fusion, which is the most common fusions as an entity ALK positive histiocytosis. Now, this is an entity that's defined by molecular analysis that has to show ALK gene translocation, typically by RNA sequencing, as well as for FISH. But I believe FISH is a less sensitive technique, especially when you're dealing with histiocytosis, because the cutoff is not validated. You have a different cutoff for lung tumors with ALK rearrangement. You have a different cutoff for ALK positive anaplastic large cell lymphomas. But in histiocytosis, it's so rare, you don't have a validated cutoff. So I would highly suggest RNA sequencing when you're suspecting a case of ALK positive histiocytosis. The key way to interpret this immunostain, it should be not nuclear. It's always cytoplasmic. It could be membranous. It could be Golgi. It could be granular, but it has to be cytoplasmic expression or membranous expression and never nuclear. And it can mimic Rosai-Dorfman phenotype, just like in this case. It can also mimic a Manchester disease. And it has a very favorable outcome, primarily because of this ALK fusion being amenable to ALK inhibitors. But the other question, is ALK immunohistochemistry enough? The answer is no. This was a case of a breast biopsy in a middle-aged female who did not have any trauma history, because you would think of fat necrosis when I've seen this collection of histiocytes, didn't have any cyst on the core biopsy, but had this histiocytes on a breast biopsy negative for carcinoma, and the breast pathologist stained for ALK. So the question was, is it ALK positive histiocytosis? So the RNA sequencing and FISH with negative for both ALK rearrangements and any ALK fusions confirmed by two techniques. I did a different antibody clone, the D5 clone, and you can see this nuclear expression. D5 is an extremely sensitive clone. We use this in lung cancer diagnostic because of sensitivity and amenability to therapy. But in lymphoma diagnostics, as well as histiocytosis diagnosis, it's preferred we don't use the D5 clone. It's preferred to use an alternate clone because of the highly sensitive nature of this D5 clone. It can give rise to false positivity, especially in histiocytic lesions. And this nuclear positivity is considered to be non-specific, and that's why this case was negative by molecular analysis for ALK fusions. So to summarize, when you have a discrepancy with molecular and immunohistochemistry, do a different clone and check for the pattern of expression. I don't know what causes this nuclear expression, but I've reviewed the raw data on this. There was a gene expression imbalance of unknown significance in this case. This patient is doing extremely well. It's just that, we don't want to call something a histiocytic neoplasm, and it's truly just a non-specific immunoreactivity. So talking about case number 3, this is a 60-year-old male who presented with abdominal pain, and CT abdomen showed perinephric thickening. As you can see, this H&E stain section is a very fibro-inflammatory infiltrates here. This caused by the small mature lymphocytes, some background histiocytic proliferations, initially thought of IgG4 disease because you can see increased IgG4 about greater than 80 per high power field, and the ratio was bordering on 40%. So by pathology, it was highly suggestive of IgG4. The patient got diagnosed as IgG4, treated with steroids, no response. Presents later to rheumatology with bilateral knee pain, and the rheumatologist happens to be a part of our histiocytosis working group, which triggered a workup for histiocytosis. When you did a complete whole body PET CT, what happened was, in addition to the perinephric thickening, you also saw this bilateral bony osteosclerosis of the knee bones. And this was worked up further with histiocytic markers proved out to be BRAF V600E mutated around chest disease. And this is a very common pitfall in ECD diagnostics, is because it can really mimic and overlap with reactive histiocytic proliferations. So unless there is like a complete immunohistochemistry workup as well as a clinical radiologic evaluation, the patients can have a diagnostic odyssey for several years without a solid diagnosis, impacting the quality of life. So ECD can mimic reactive proliferations, especially BRAF V600E is present in 50 to 60%. So it's highly recommended that we employ this immunostain in routine cases, besides excluding reactive proliferations such as infectious disorders as well as IgG4 related disease. IgG4 can be associated with a histiocytosis. You can have increased IgG4 positive plasma cells in Rosai-Dorfman disease, in Adam chest disease, and so forth. So, that doesn't really exclude the underlying histiocytic phenomenon. So it's always good to employ a panel of immunostains. So this is a graphic representing ECD. ECD is not a histopathologic diagnosis. It has to have this mandatory clinical plus radiology plus pathology for molecular analysis specifically. In terms of the classic pathognomic radiologic findings, it has this bilateral bony osteosclerosis of the knee bones in over 95% of the cases. Up to 40 to 70% of the cases will present with right atrial mass. You cannot identify this by routine imaging. You need to have a cardiac MRI. And this is done especially when ECD is suspected, given the presence of other pathognomic findings. About over half of the patients have this peri-aortic coating, which is called the coated aorta, characterized by this infiltration of histiocytes surrounding the aorta. Endocrine manifestations can precede ECD diagnosis for several years, the most common being diabetes insipidus. It's now known as arginine vasopressin deficiency, AVP. This diabetes insipidus can present as 10 years before you can even diagnose a patient with ECD. I think my longest has been 10 years, 10 to 15 years. Nervous system, it can involve any lesion more than dural presentations, which is more common in RGD as well as LCH. The most common involvement in ECD would be the parenchymal involvement. In orbit, similar to RGD, it can have intraconal disease presentations. Skin lesions, just like Rosai-Dorfman disease, can present as skin lesion, but most of the time you see this yellowish hue because of the foamy histiocytes, the lipidized nature of the histiocytes presenting as xanthelasma-like lesions. And in the retroperitoneum, it presents as perinephric thickening, which is also termed as hairy kidney. When it has testis presentation, more often than not, it's a mixed histiocytosis, is ECD presenting with Rosai-Dorfman disease. So this is a summary slide of this classic pathognomic radiologic findings. Now, focusing on the pathology, you don't have a defining pathognomic marker in BRAF V600E negative cases. If it's BRAF V600E positive, that's a diagnosis of, it would be compatible with ECD in the appropriate clinical and radiologic context. I still would not call ECD outright. It has to meet the classic radiology and clinical, the spectrum of ECD manifestations. Otherwise, I would just classify as histiocytic neoplasm, BRAF V600 mutated, and put a comment on the differential being ECD. We have a recent series that's going to be coming up in the next couple of months or so, where we found that cyclin D1 is really highly expressed or overexpressed in ECD histiocytes, greater than 90% of cases, which can be used as an ancillary marker to distinguish from reactive histiocytic proliferations. So this could be really helpful in BRAF V600 negative cases. Again, this is not a diagnostic marker by itself. At least it will guide both the pathologists and the clinicians to do further workup with molecular analysis and a complete radiologic evaluation to entertain the differential of ECD, so we can prevent this diagnostic odyssey that occurs in these patients for several years. So case number 4, this is a patient who presented with multiple skin lesions. You can see here, this is a two-tone type giant cells, and this is a proliferation of histiocytes here. This is a xanthogranuloma. But don't stop there. So the purpose of this case is that immunophenotypically, it has some aberrancy. It has xanthogranuloma lesions can have S100 expression, mimicking a rosette orphan phenotype in up to 30% of the cases. But the key is your histology in combination with the immunohistochemistry here. So this patient had an abnormal immunophenotype, variable expression of cyclin D1, S100 diffuse expression, had a dermal macrophage phenotype, which is characterized by this expression of CD163 and factor 13A. PET-CT was negative for any other systemic involvement. This was isolated cutaneous lesions. Now, we always come into the diagnosis of is it juvenile xanthogranuloma or adult onset xanthogranuloma? It's mostly the age. I think there's no reliable cutoff, but in general, as a rule of thumb, GXG is a disease of pediatrics. AXG is a disease of adults. We do see cases where you say disseminated GXG in an adult. That can happen, but again, it's all a semantic. It's okay to call it systemic xanthogranuloma in an adult. This is an area of ongoing, speculation with terms of terminologies, but main thing to remember, it overlaps with ECD by morphology. We cannot tell the difference between ECD or GXG or adult XG. They need to evaluate by radiology and clinical presentations. So in a broad overview, in a broad sense overview, when there is an aberrant immunophenotype or a clonality demonstrated in a xanthogranuloma lesions, always think about histiocytic neoplasm workup. In general, XG family of lesions are mostly cutaneous. Less than 5% can have disseminated involvement, including the brain. But when they do, they lack pathognomic radiologic findings that present in ECD as described before. Histopathologically, there is no defining marker that delineates one versus the other, but there are subtle differences between XG family and Oramas-Mogrovejo disease, although not disease defining. But we can try to at least propose a differential diagnosis based on the immunophenotype for favoring xanthogranuloma versus Oramas-Mogrovejo disease and have them work up by radiology evaluation. In general, gene fusions are way more common in xanthogranuloma as opposed to Oramas-Mogrovejo disease, where point mutations are way more common. There is also a subtype of JXG which can have beta V600E mutation. The bigger question comes if those beta V600E mutated JXG are an early spectrum of Oramas-Mogrovejo disease. We really don't have an answer for that. I think we really need to study this in prospective trials and studies to see how these patients fare out, especially in adults over 18 years. This is the other C group of histiocytosis. When you don't have an immunophenotypic aberrancy, when you don't have a clonality demonstrated by molecular analysis, there is a whole different differential diagnosis platter that comes in xanthomatous lesions. So, in the interest of time, I'm not going to go over this, but just think about xanthogranuloma as not just like a benign entity. It's something that needs an immunohistochemistry workup. When you have an abnormal immunophenotype, have a very low threshold to get for NGS, as well as have the clinician do a radiologic evaluation. When you suggest radiology, it has to be a whole body PET from vertex to toe. Most PET stops at mid-thigh, so you have to emphasize whole body PET. Hence, an evaluation by by a histiocytosis person is always good for a thorough workup in these patients. I often put a comment to refer to our UAB histiocytosis program in these patients to have a comprehensive evaluation. So talking about dendritic and Langerhans cell phenotype, compared to the monocyte macrophage phenotype, this has a fairly straightforward phenotype, but can have its own challenges too. Langerhans cell histiocytosis is most the trainees have known this bias as coffee bean shaped nuclei because of the grooving of this nucleus. It's characterized by the positive immunostaining for both CD1A and Langerhans. This Langerhans expression is what used to present as Bruback granules in electron microscopy, which we no longer use these days. But in general, Langerhans cell histiocytosis is positive for CD68. Majority are CD163 negative, and that is the dendritic cell nature of the disease. Dendritic cells are usually CD163 negative. If you see positivity, they're usually admixed macrophages and not the true dendritic cells. There can be aberrancy in a subset of LCH that can show CD163 expression, but the vast majority are negative. So similar to the other histiocytic neoplasms, you can have cyclin D1 expression in LCH, which will really help you to distinguish between reactive Langerhans cell proliferations and true neoplastic Langerhans cell proliferation. This is very important in the lung, especially when you're dealing with the burnt out LCH. This is something that is reactive, causing this reactive Langerhans cells. Beta V600E, similar to ECD, is present in over 50 to 60% of Oramas-Mogrovejo, similar to ECD, is present in 50 to 60% of LCH cases as well. And oftentimes immunohistochemistry will demonstrate this, but I will always suggest lab to lab there is variations in BRAF V600E clone. So it's always good practice to confirm this positive immunostaining by molecular analysis. So the key features, similar to Adam-chested disease, this is a multisystemic disease, but can present as a unifocal lesion all the way to a multisystemic presentation. In the kids, it's most commonly present in the bones as lytic bone lesions, but it can also manifest as skin lesions, and nodal disease is extremely rare. But in terms of endocrine manifestation, it can emulate the findings that we see in ECD presenting as diabetes insipidus for years. I've had a case 5 years, diabetes insipidus, eventually diagnosed as Langerhans cell histiocytosis in the bones. So pulmonary LCH has a unique physiology, is more common in almost always in smokers. When it's an isolated presentation, it can still have a BRAF V600E mutation, but most often time you stop the smoking, it goes away. But you can have secondary pulmonary involvement in systemic Langerhans cell histiocytosis. So the key pitfall is in nodal disease, you can have paracortical expansion by CD1A and Langerhans cells, and the CD1A and Langerhans cells will be the similar pattern of CD3 in the paracortex. This is a dermatopathic lymphadenopathy, which has the similar immunophenotypic features of Langerhans cell histiocytosis. LCH is a nodal sinus disease, which means there should be sinus expansion and it's not a paracortical expansion. Can also employ cyclin D1 marker, but it's really a pattern of distribution in the node that distinguishes dermatopathic reactive lymphadenitis from a true Langerhans cell histiocytosis in the node. And in terms of pitfall, this is especially important for lung pathologists when you're interpreting BRAF V600E. It stains the cilia. I think it's one of the most beautiful staining and cross-reactivity of a VE1 antibody that you can see with the ciliary axonal dynin that has this painted appearance on any ciliated organ. You can take fallopian tube, you can take choroid plexus or Rathke's cleft cyst or the ciliated bronchial epithelial cell, you see this nice BRAF V600E staining. So when you're evaluating a macrophage-rich lesion in the lung, the macrophages can sometimes try to clear the debris of the ciliated bronchial epithelial cells, simulating a positive BRAF V600E expression in the macrophages. But whereas in reality, they are just cilia inside the macrophages. So, you have to keep this pitfall in mind when you're interpreting BRAF V600E. Case number 5, this is a 16-year-old male who presented with lytic bone lesions, and the bone lesions was actually stained with CD1A called as Langerhans cell histiocytosis. And the patient was treated, never responded, came back for a second opinion. When came back for second opinion, oftentimes in many places you don't have Langerhans immunostains, so as a result of which, they call LCH just based on CD1A. But this case, when it came for a second opinion and I did CD1, when Langerhans and cyclin D1, they're both negative. Clearly not Langerhans cell histiocytosis. And then when you look into this more, you have so much eosinophil, CD30 positivity. This was a case of classic Hodgkin lymphoma mimicking Langerhans cell histiocytosis. Unfortunately, this is a common misdiagnosis in pediatrics. In pediatric cases, when you have lytic bone lesions, the first diagnosis is always Langerhans cell histiocytosis being the most common presentation. In adults, we don't even work out for Langerhans cell histiocytosis because the most common is plasma cell leukemias and myelomas and lymphomas. So the reason you have the CD1A expansion classic Hodgkin is just the immune microenvironment that's very rich in the expansion of the dendritic cells. So that has to be kept in mind when you're dealing with the differential diagnosis, especially in pediatric cases. So indeterminate cell histiocytosis is essentially similar to Langerhans cell histiocytosis, the only exception being it is completely negative for Langerhans. So never diagnose an LCH without a Langerhans stain. CD1A is never enough. You need to have both CD1A and Langerhans to evaluate for histiocytic lesions, because this entity of indeterminate cell it's a completely different prognostic course compared to Langerhans cell histiocytosis. Predominantly, this presents as skin lesions, but indeterminate cell histiocytosis can be notorious in its recurrence rates and as well as treatments. So it has to be distinguished from true Langerhans cell histiocytosis. And in a primary case of indeterminate cell histiocytosis, majority do harbor this fusions, ETV3 and CA2. They do upregulate the MAP kinase pathway. So case number 6, this is a patient, 11-year-old boy with a history of T lymphoblastic leukemia, diagnosed 1 year ago, and had MRD negative later in the first month, continue to have MRD negativity. MRD is minimal residual disease. We evaluate for the leukemic burden post-treatment of the primary leukemia. So we evaluate usually by flow cytometry, and it also can be evaluated by molecular analysis. 15 months later, he presents with this Anasaka pleural effusions, and CT sinus showed this really mass lesion that was biopsied and showed sheets of this large pleomorphic cells. It was negative for all keratins, melanoma markers, lymphoma markers, and it was diagnosed as polydifferentiated malignant neoplasm. It came for a second opinion just because it has a history of heme malignancies, so it was reviewed in hematopathology. I will tell you this neoplasm CD45 can be downregulated, so CD45 alone doesn't exclude a hematopoietic process if negative. So this was worked out for a histiocytic process, and it was positive for histiocytic marker CD68, 163, diffusely positive for cyclin D1, variable expression of X100, OCT2 being diffusely positive. PD-L1, I'll come back to this in the upcoming slide. This was a case of histiocytic sarcoma. It also showed diffuse involvement in the bone marrow in this patient. In a patient with leukemia or any prior lymphomas, you can have this malignant histiocytic neoplasms that develops in the setting of transdifferentiation, which means one lineage switches to a different lineage because of an expansion of a subclone post-chemotherapy of the primary leukemic or lymphoid clone. This case had a positive T-cell gene arrangements, which was favored to represent a transdifferentiated process. I say favor because you need to have the primary tissue to demonstrate the shared clonality. Here, the primary tissue was not there, so it was consult. So this was treated like, or diagnosed and followed up like a transdifferentiated malignant histiocytic neoplasms. And RNA sequencing did show a RAF1 fusion, which also triggers a MAP kinase signaling pathway. So diagnosing malignant histiocytic neoplasm, this really mimics your true polydifferentiated malignancies, carcinoma, sarcoma, melanoma, and aplastic lymphomas. You rule out the big four. Before classifying this as undifferentiated process, I would recommend to at least do a histiocytic lineage markers like CD68, CD163. PU1 is a very good marker too. I'll show you up a slide in the upcoming few slides. So it's important to exclude a histiocytic lineage neoplasm. Classification of malignant histiocytosis has very different subtypes. To the clinician, it doesn't matter. It's malignant histiocytic neoplasm. It doesn't matter what subtype. But to the pathologist, it absolutely matters because you need to phenotype it and differentiate from other epithelial malignancies and polydifferentiated malignant neoplasm. In the interest of time, this could be an hour talk by itself. But we published a paper on the phenotypic spectrum of this neoplasm, which entails the entire details of these different subclassifications for routine diagnostic practice. So in terms of PD-L1 expression, your malignant histiocytic neoplasm is what I would consider as a histiocytic urgencies. The clock is ticking. We don't know which patients do well. I have had patients who die in 3 weeks from diagnosis to those who survive greater than 2 years. So I don't know which patient will survive. I don't know which patient will respond to treatment. It's always a puzzle for us. It's still a puzzle for a hematologist specializing in histiocytosis. But in general, this is a case of a middle-aged female who had this mediastinal mass that showed this histiocytic sarcoma. And then interestingly, India showed a MET exon 14 skipping mutation, which is most common in non-small cell carcinomas, which made the hematologist question, is it truly histiocytic sarcoma or is it a lung cancer? So it was truly histiocytic sarcoma. There was no doubt. It was 100% histiocytic lineage. Interestingly, the patient didn't respond to targeted therapy, which is very unusual in general to not respond to a targeted therapy. But like I said, MHN is a very promiscuous entity. It doesn't respond to many therapies, even if there are targetable mutations. So we did PD-L1, it was present in greater than 95% of these tumor cells. The way we score it is only the tumor cells. We don't do CPS in heme diagnostics because we can't do CPS in histiocytosis. They are your immune cells. Impossible to differentiate reactive immune cells admixed with neoplastic histiocytes. So you only do TPS, tumor proportion score. It was greater than 95%, treated with the checkpoint inhibitor, pembrolizumab. Patient showed a remarkable response within 42 days of therapy. She's at 3 years right now, and she's doing extremely well. So it really emphasizes the need for exploring markers beyond the routine diagnostic immunohistochemistry to identify those that can be potential candidates for immune checkpoint inhibitors. And we published a paper that talks about the extent of PD-L1 expression in malignant histiocytosis to summarize PD-L1 greater than 30% in malignant histiocytic neoplasms, typically associated with multisystemic disease, and do show good response rates for immune checkpoint inhibitors, although we do need a larger series before we can validate our findings in other cross-sectional studies. So practical challenges of the scope, talking about underdiagnosis, now is the time for overdiagnosis. So this was a case of a patient presenting with a thigh mass. You can see this kind of large epithelioid appearing cells. Some of them are spindle, has this diffuse expression of CD68 and 163, called the histiocytic sarcoma. Since it was a heme diagnosis, it came for a second opinion, specifically directed to me on this case. Is it histiocytic sarcoma? So when you're looking at the case as a high power, your true tumor cells are negative. What is marking is your adjacent histiocytes. This was a case of undifferentiated pleomorphic sarcoma. And oftentimes soft tissue sarcomas can have so many admixed histiocytes, and they could show a varying degree of reactive atypia, but caution must be warranted in what cells we are really analyzing the expression of these histiocytic markers. Scenario number 2, this is the skin lesion in the patients with like sheets of epithelioid, overtly malignant appearing cells. Again, all markers negative for epithelial markers, melanoma markers, and also lymphoma markers. CD68 positive, 163 positive, initial diagnosis, histiocytic sarcoma. On further examination, again, the neoplastic cells were truly negative. What was staining was your adjacent histiocytes here. P1 is a very useful marker because it's a nuclear marker. It really sharply marks the histiocytes and helps you to differentiate from the large tumor cells. You can see this tumor cell will be 3 to 4 times the size of your admixed reactive histiocytes, whereas your CD68 and 163 are membranous and cytoplasmic markers, which really confuses the interpretation for us as a diagnosing pathologist. Like I said, cyclin D1 can be upregulated in several tumors, and so this was upregulated in this tumor as well. But this is not a histiocytic tumor. This was a pleomorphic dermal sarcoma as diagnosed by the dermatopathologist. So key takeaway points, I would recommend at least 2 histiocytic lineage markers and dendritic cell markers necessary for diagnosis. Admixed histiocytes and solid tumors can show varying degrees of reactive atypia, which needs to be kept in mind in interpretation and not to overcall these as true malignant histiocytes. Interdisciplinary consultation with workup with bone and soft tissue dermatopathology are very crucial in distinguishing this from true histiocytic malignancies. My approach to workup, we are kind of nearing the end of the hour, so I'm just going to give a brief outline of this. In general, when there is a histiocytic infiltrate mass forming and either there is a pathology suspicion or the radiologic or clinical suspicion, in UAB, we have a big histiocytosis program. So every pathologist there is very aware of any histiocytes. They usually come to me. Majority of the time, they are not true histiocytic neoplasm, but the fact of building that awareness has really helped us catch cases at much earlier stage. So when it's evaluated, I usually do a panel of immunohistochemical markers. This is just like a baseline panel. But for main distinction, I think you need to go beyond. We have a histiocytic panel for IHC and UAB set up, and they include all of these markers. We don't have Langerin. We still send it out when CD1A is positive. I then send it out. If not, then I don't do Langerin. So, key differences would be Rosite-Hoffman disease. You have this S100 and OCT2 expression. ALK positive histiocytosis, I will never diagnose based on IHC only. I will always need a molecular confirmation. It's not a nuclear staining. It has to be cytoplasmic, membranous, Golgi, or granular staining in the cytoplasm. ECD is a clinical diagnosis, clinical radiologic diagnosis. Whenever I see a case of xanthogranuloma lesion, my diagnostic area would include xanthogranuloma family of histiocytic lesions with a common section referring to the hematologist for a comprehensive radiologic evaluation to exclude and evaluate the possibility of ECD. If ECD is excluded by radiology, then you can call it an adult onset xanthogranuloma or juvenile xanthogranuloma based on the patient age. And we usually do NGS for all of these xanthogranuloma cases, especially when there is an abnormal immunophenotype or a clinical and radiologic suspicion. Classic dendritic cell tumors, it's mainly diagnosed by employing this immunohistochemical markers for CD1A and Langerin. Both should be positive for an LCH. CD1A positivity, Langerin negativity is indeterminate cell histiocytosis, also called as indeterminate dendritic cell tumor. Malignant histiocytosis, again, has an overlap of both these phenotypes. I put the QR code here. It's very hard to cover MHN within this talk of histiocytosis, but again, it's a whole different separate talk, but just keep in mind to work up for histiocytosis before putting it in the category of poorly differentiated malignant neoplasm. There is another entity called NTRK rearranged histiocytosis, an emerging entity. Just 2 papers came out a few months ago. It's nothing but pan-Trk IHC positive in the histiocytes and molecular analysis showing NTRK fusion. More commonly in kids, it's defined by NTRK fusions, but pan-Trk IHC also shows this expression. So, this needs to be keep in mind when evaluating for NTRK rearranged sarcomas. So workup for histiocytic markers, they have really good prognosis when treated with TRK inhibitors. So in talking about the last section of this talk is this multidisciplinary working group. It was established in 2017 when I was a first-year resident, and I'm very grateful to my mentors, Dr. Karen Reck and Dr. Ronald Go. I've learned so much from them over the years. They taught me my first case of Rosai-Dorfman disease. I saw my first patient with Dr. Go in the clinic, and the same patient biopsy with Dr. Reck in the scope. So I think it's been a very enriching educational experience over the years working with every member of the team. This was expanded to 2019 when my colleague Dr. Gaurav Goyal, who also trained at the Mayo Clinic, went to UAB and then established the histiocytosis program on the clinical side. So we studied the impact of our rare disease group, working group discussion, and we found that among 40 cases we worked out from 2017 to 2019, at least 1/3 had a change in diagnosis or treatment. This is a major impact for rare disease. In UAB, I just had reviewed cases that were second opinion from the clinics. These were not directed consults, these were not in-house cases. Second opinions at clinic had the same 1/3 change in diagnosis. I joined UAB in July of 2022. This is up to 2024. So I think a small awareness program can make a big change in the patients and families' quality of life. So we have a new website. This was just launched a few months ago. It's curehistio.org. This is a Histio Care Network. We rebranded our name from Histiocytosis Working Group to Histio Care Network. It includes several institutions. In fact, from University of Minnesota, we do have clinical hematologists sometimes joining in to present cases from here. So I think it's also expanded to other institutions. And we also have a portal for resources for physicians, patients, families, as well as for pathologists or other clinicians who have a question or a case they can present. There is a web form that they can submit. We meet monthly, and I think this has been going on for almost from 2017 till now, every month, second Thursdays, noon, 12 to 1 Central Time. So I think this has been a very good group to discuss and learn cases and make a true difference in patient care and families. On that note, I take this opportunity to thank all the patients and families who trust us with their care and my entire divisions of hematopathology at both Mayo Clinic and UAB Pathology and all the organizations for the incredible amount of work they're doing to impact the advancement of field in histiocytosis. With that, I thank you everyone for your attention. We're at the end of the hour, but I'm happy to take any questions. Thank you.
I have a question.
Yeah.
For case number 1.
Yeah, you want me to go to the case number? Yeah.
So what made you actually go to a diagnosis of that? I mean, like, I'm not seeing like there's a lot of exercise that is CD63 and this.
Yeah, that's a great question, because whenever you see this, it came to me with a question of there is a lot of histiocytes. Whenever there is something abnormal, they usually direct it to me. I think there was a panel of immunohistochemistry workup that was done. I've seen very aggressive clinical phenotypes. So this was not a shocking presentation for me. So, the morphology wise, it's a very cytology, this round to oval histiocytes, they're forming sheets. It's very unusual in a carotid wall where you don't have cholesterol collapse in an otherwise atherosclerotic plaque. There was also a separate plaque, tumor mass, which was questionable Rosai-Dorfman disease, but it had so many tumor cells, I was not able to delineate the cells very well. But when we did the immunohistochemistry on here, just lit up like a Christmas tree, supporting the diagnosis.
Up to on this one.
Correct. Up to and cyclin D1 too. Correct. But I didn't show that here because I felt like, this was compelling evidence. In the vast majority of the practice, I think OCT2 and cyclin D1 is still not done, but I think S100 and CD163 is typically good enough for a diagnosis of RDD when you have a right cytology.
So cytologically, you have like a barrel or something?
Sorry, come again?
Cytologically, what do you have on this side?
Cytologic is the nuclear features. They have this enlarged round to oval uniform nuclear with conspicuous nuclei and abundant cytoplasm, and with the immunophenotype, it supports the diagnosis. It's always very characteristic. It can overlap with reactive proliferation, but this degree of S100 you don't tend to see in reactive histiocytosis.
So very quickly to clarify, excellent presentation.
Thank you.
Based on a review of histiocytic neoplasm in general, we have to deal with this frequently in thoracic pathology.
Yeah.
As many of them affect the lungs. But to clarify CD163. So in LCH, adult type, for example, the neoplastic cells, yes, they are negative for CD163, but it is very useful because the monocytic infiltrated associated, which is part of the environment of the seeds, is always positive.
Absolutely.
For CD163. So people are confused.
Correct.
You know, is it positive or is it negative? And also you can use it for differential diagnosis, for example, because in Chester, CD163 should be positive in.
Correct. Yes, it has to be positive in ECD and JXG. Correct. Yeah. I think LCH, you can have a lot of CD163 macrophage infiltrates, and sometimes in kids, especially when you're following up, the macrophage infiltrate is so much that you tend to not identify that LCH cells, and they could actually get a differing diagnosis of macrophage neoplasm and not go into the realm of LCH. LCH can have varying phenotypes and phases, but I think in the end, the main key point to prove is that the CD1A and Langerhans infiltrating cells can be associated with a lot of CD163 positive cells that are CD1A and Langerhans negative.
I just want to check if there is any question here.
No questions.
I think we don't have more questions. And thank you so much, Dr. Ravindran. This was an excellent presentation. And thank you for sharing this knowledge with us. So thank you.